pericardial fistula in a patient with a Roux-en-Y gastric.
Calculated appearance. Okay, thank you.
Okay, thanks. Our next speaker is Dr. Mohammed, and we'll be talking on enteric pericardial fistula in a patient with a Roux-en-Y gastric bypass.
Thank you, sir. Okay. Good evening, everyone. My name is Wael Mohammed. I'm a second-year medicine resident still at University of Missouri, Kansas City, and thank you so much for having me today. I'm going to be presenting a case of enteric pericardial fistula in a patient with a previous history of Roux-en-Y gastric bypass. I have no disclosures. So just a quick background. As you all know, Roux-en-Y gastric bypass is a frequently performed bariatric surgery in the US. The mortality rate is less than 1%, with operative complications rate less than 5%. Chronic complications include anastomotic stricture, marginal ulceration, gastric fistulae, and other chronic complications like malabsorption. Post-Roux-en-Y gastric bypass enteric pericardial fistula is a rare complication with only 6 case reports were reported on literature. And till the moment, there is no clear approach in managing non-surgical patients. So that's why we are presenting our case today. We just want to share our experience. We had a patient of a 54-year-old gentleman, previous history of Roux-en-Y gastric bypass 4 years prior to presentation with fever, dyspnea, and epigastric pain. A cross-sectional imaging was performed in addition to an echocardiogram that showed a pneumopericardium. Multiple percutaneous drainages were done by interventional radiology, but unfortunately failed with reaccumulation. Cultures from the pericardial fluid grew bacteria suggestive of a GI origin. That's why we started to think about a possible connection between the pericardial cavity and the GI tract. And hence we started the fistula workup, starting with an esophagogram, which was negative. This was followed by a CT with an oral contrast. And as shown here, the contrast is trickling from the pericardial cavity down to the GJ anastomosis, as shown by the yellow arrow here. Then we opted a multidisciplinary approach. First of all, we got our surgery colleagues who deemed the patient as a non-surgical candidate. And then from our standpoint, we started medical therapy, and this was in the form of IV antibiotics, having the patient MPOs to start with, starting IV antibiotics, IV PPIs, in addition to TPN for nutrition. And then we thought about the use of upper endoscopy for diagnostic purposes, but we also wanted to think about the possible therapeutic options. So we took all the precautions to avoid any theoretical tension pneumothorax. So we had the procedure done completely in the operating room, with having our cardiothoracic surgery colleagues performing a pericardial window with drain placement before endoscopy, and this to allow any possible air leak. And this was done with minimal insufflation for the same purpose. And we used cap-assisted endoscopy for a better visualization and minimizing the timing of the procedure. As you can see here, you can see a marginal ulcer measuring around 1.5 times 1 centimeter with a central fistula, as shown by the green arrow. Then after being done with the diagnostic purpose, we started to think about what kind of therapeutic options can we do. We started to think about over the scope clip And unfortunately, due to the indurated tissue, which was hard to suction with possible misfiring, and the fear of clipping the pericardium or the pericardial vessels, this, this wasn't amenable to be done. And then we thought about possibly placing a lumen opposing metal stent, and unfortunately, due to the altered anatomy, this wasn't possible as well. In addition, both of those options, they have very limited data or literature supporting those techniques. And we thought about possible vacuum therapy, but unfortunately we didn't have this, technique in our institution. So we decided to continue medical therapy. And then the patient's condition improved. He was discharged out of the ICU down to the floor and then discharged later on after an 18 days of hospital stay. He was transferred to a dedicated tertiary center specialized in bariatric surgery. Unfortunately, he passed away a few weeks later on, but I just wanted to share our experience in addition to prior 6 case reports reported on literature. Most of the patients' age was hovering around between upper 40s and low 50s, and the mean number of years of previous room-wide gastric bypass prior to presentation was around 15 years, and all of the previous case reports, the endoscopy was mainly diagnostic rather than therapeutic, and the main management was basically cardiothoracic surgical repair. For the prognosis, it was dim, unfortunately. More than 50% of those patients, died within few days to weeks following the procedure. So we are concluding the following. Enteric pericardial fistula is a rare complication following Roux-en-Y gastric bypass. Always suspect in patients presenting with cardiac symptoms or signs. Contrast imaging can produce false negative results. A multidisciplinary approach is always needed. Endoscopy is safe with precautions, and its role is mainly diagnostic rather than therapeutic. Endoscopic management options are limited with scarce data on literature. Surgical treatment is favored following failure of conservative measures. The prognosis is poor. And here is my questions to the audience. Would you consider performing an upper endoscopy for a suspected enteric pericardial fistula? Any precautions to be taken? Option A, no, it's risky. I'd recommend conservative therapy only. B, it's safe to perform an endoscopy and no precautions are needed. And then finally, C, will consider a cap-assisted endoscopy with minimal air insufflation after a pericardial window is performed by cardiothoracic surgery.
C.
Okay. Thank you. Yes, correct. I agree with you all. So, yep, that's the correct answer. And my key takeaways for you guys. For a suspected enteric pericardial fistula, consider a cap-assisted endoscopy with minimal air insufflation after a pericardial window is performed by cardiothoracic surgery. Endoscopic management for post-Roux-en-Y gastric bypass enteric pericardial fistula options may include over-the-scope clip closure if it can hold to the surrounding structures, aluminum opposing metal stent if the anatomy allows, possible endoscopic vacuum therapy, but this will need very, very experienced interventionist. And thank you so much for listening to me today.
All right. Thank you. Comments?
Yeah, I actually had a case like this as well. The patient perished very shortly after the diagnosis. I mean, I just don't think pH of 1 is good for the heart. It's just not compatible with life typically. I do have to say the mechanism of this is that the patient obviously had developed some type of a hiatal hernia, because you have to imagine how did it get above the diaphragm, right? So that's an important mechanism. These are tough. They're always going to be on the left side. They're never going to get an en face view. I would actually argue that if you're going to look, you better try something. Otherwise, I wouldn't go look. Yeah. In other words, if you're going to look, prepare for therapy if you can. A lot of these cases, I have to say, it's a little bit of a philosophical view, but these patients are quite doomed in some ways. And so, as my attending once said, it's a free ride. The patient's outcome is already pre-written. So if you can help them, then you're a hero. If you don't, it was written already. Yeah, thanks.
Yes, sir. Thank you so
Yeah,
much.
I think that was great. I just think, I mean, this is the true case of heartburn, right? As you see.
I agree.
Dad joke. No, but I think you're absolutely right, and this ties in nicely with the other cases that we've had so
Yeah,
far. You know, there was a question on why go in and do it, and I think if the patient is already either looking at a surgery to begin with, or unfortunately they're gonna die, it'll lead to their demise anyway, and you can help, whether that's in a palliative terms or whether that's some sort of prognostication. I always particularly find that when the surgeon's asked to do something in these scenarios, it's sort of the last effort, and if it seems reasonable either from a patient point of view, an ethical point of view, or a patient care perspective, then it's reasonable. So I had a case like this as well, and unfortunately it led to the demise as well. But if you're going to go in, you should at least try to,
So what did you do in that case?
In this case, we couldn't do anything. No, now I'm wondering the XTAC system might be a reasonable thing if you had that in your armament to do with a large defect there. I don't know how that would go, because I would be afraid of using a large suture system or something like that and grabbing anything in there. I mean, no. But the XTAC system, because they don't go very deep, might be something nice if you're looking at just the last ditch.
Or if you don't have an XTAC system, I'm wondering about the nylon loop closure with clips. So this is where you place with a dual channel scope, and you put in a nylon loop over the area. You start clipping the loop with standard through the scope clips, and then you cinch it down.
That's called the King's loop technique.
Yeah.
It's tough to do. I mean, this is stomach, so it requires a lot to cinch that down.
Yeah.
A suture could be tried.
Yeah.
Don't hit the heart though.
Yeah.
Beating right behind it.
Does the panel have any experience using, I like the XTAC idea of using an Endomax tent, going all the way across the room and wide, just sealing it up with a fully covered device like that?
I have used the Endo Giant one, the 23 one, and I've gone across all the way
Trying to get
to
good closure in these spaces, but
yeah, I don't think you're gonna get a good seal. Yeah, it's the stomach. It's a mobile animal. I'm not. It's tough. Yeah. I'm not sure mankind's figured this one out yet. Last one.
Thank you, sir.
Okay,
Thank you so much, everyone. Thank you.
All right, so our final presentation will be by Dr. Patel, intestinal perforation.